Great. Can you hear me okay? Thank
Yes.
you for inviting me to present on one of my favorite topics, the surgical management of brain metastasis. My goal is today to cover three things. First, to review the landmark studies that establish the role of surgery in the management of brain metastasis. Next, to discuss the impact of surgical technique and the nuances of patient selection, and then discuss two challenging topics, specifically the surgical management of patients with multiple brain metastasis and the surgical considerations for patients with radiation necrosis and failed SRS. So the pivotal role of surgery was initially established after the completion of two landmark randomized trials, both shown here. Both trials were focused on single brain metastasis. The first trial on the left here was performed by Patchell, where they randomized 58 patients to receive surgery plus radiation versus radiation alone. The authors reported that patients who had surgical resection were afforded longer median survival times. They also had significantly lower rates of local recurrence and maintained functional independence for a longer period of time. The second clinical trial there to the right also used the same randomization schema with 63 patients, and they duplicated the results of the initial study, reporting better survival and better functional outcome in patients that actually had surgery, solidifying the role of surgery in this patient population. In addition to the trial data, there are several well-defined clinical benefits of surgical resection, particularly for large lesions, and I've listed them here, specifically rapid relief of mass effect, addressing elevated intracranial pressure, relieving CSF obstruction and hydrocephalic, particularly in lesions that are in the posterior fossa. Surgery is also the quickest way to relieve malignant cerebral edema and decrease the time on weaning off of steroids. And surgery can also aid in diagnosis in the setting of an unknown primary. It is also established that patients receiving a gross total resection have better outcomes than patients receiving a subtotal resection, as demonstrated by this study of retrospective analysis of 157 surgical patients, where they showed a statistically significant advantage for patients having a gross total resection versus patients having a subtotal resection. Notably, even with the availability of upfront stereotactic radiosurgery, which is minimally invasive, the current data still favors surgical resection, especially for patients with larger metastatic lesions. In this 2017 study, the authors compared the outcome of patients receiving single fraction SRS alone versus surgery in SRS, and they focused their study on large brain metastases. And once again, the surgery group showed a lower rate of local recurrence and were afforded longer median survival times. So now I want to spend some time talking about surgical technique and its impact on outcome. At our institution, we both advocate for and strive to accomplish en-bloc resection of all brain metastatic lesions. Traditionally, brain mets have been removed in what we call a piecemeal fashion, where the lesion is internally approached and debulked and then removed in multiple pieces. En-bloc resection, on the other hand, entails circumferential dissection of the lesion along the tumor borders of the tumor cortex interface without violating the tumor capsule and avoiding spillage of contents into the cranial cavity. From a purely technical perspective, en-bloc resection reduces intraoperative bleeding because you don't have to get into the lesion, which can sometimes be hypervascular and increase surgical time and blood loss. And en-bloc resection also allows for better definition of the surgical borders and improves your chance of obtaining a radiographic gross total resection because the tumor comes out in one single piece. In addition to those technical benefits, en-bloc resection offers other additional advantages. If I can turn your attention to the paper on the right there, this is actually an MD Anderson study where my colleagues evaluated the outcome of 570 surgical patients to determine the impact of surgical technique on patient outcome. And they reported that piecemeal resection carried a significantly higher risk of local recurrence compared to patients undergoing an en-bloc resection. In a later study that is shown there below, this same group evaluated whether this aggressive circumferential dissection required for en-bloc removal was safe compared to piecemeal resection, particularly in the setting of tumors located in functional or eloquent cortex. This study included over 1,000 patients, and they found that en-bloc resection did not, in fact, carry an increased rate of complication, specifically neurological complication, compared to piecemeal resection. So So all in all, we've confirmed that en bloc resection to be both safe and a more oncologically effective surgical strategy. In addition to reducing local recurrence, it has been demonstrated that surgical technique can also impact patients' risk of developing leptomeningeal disease, which you all know leptomeningeal disease is a devastating subtype of CNS metastasis characterized by dissemination to the cerebral spinal fluid and carries a very poor prognosis. In this study here, actually also out of MD Anderson, on the study to the left, the authors evaluated whether surgical resection carried a higher risk of developing LMD compared to radiosurgery for posterior fossa lesions. Interestingly, the authors reported that piecemeal resection carried a higher rate of LMD compared to patients undergoing en bloc resection. Furthermore, on the paper on the bottom there, the authors also did a similar study focused on supratentorial lesions, and they also found in this study, similarly, that piecemeal resection also carried a much higher risk of LMD with a hazard ratio of almost 6 compared to en bloc resection. And lastly, in terms of surgical aspects, there are some newly reported intralesional qualities that can also contribute to the development of LMD. In this recently published paper to the right in 2019 in Neurosurgery, the authors demonstrated that both hemorrhagic and cystic lesions, both of which can be more challenging to obtain in en bloc resection, had higher rates of leptomeningeal disease compared to patients without these characteristics. So now that we know that how we're going to do surgery, we have to decide who we're going to do surgery on. And there are several key factors that go into our patient selection in metastatic patients. Traditionally, the ideal surgical candidate has the characteristics I list there. Classic RPA class 1 patient that has an age less than 65, has a KPS greater than 70, and controls systemic disease. And even better from a surgical perspective is if they have a single lesion that's accessible and a non-eloquent cortex. However, we all know, especially at our institution, that many patients do not meet this very defined, clean characteristics. And I put some examples for your consideration. First, this patient here that came in with a KPS of 50 and a large leader in the motor strip, he has a KPS of 50 because of his hemiplegia. So strictly speaking, this functional status is suboptimal based on classical traditional criteria. However, if we can turn this KPS of 50 into a KPS of 70 or 80 with resection, well, that changes the whole clinical picture. Similarly, with patients presenting with uncontrolled systemic disease. At first glance, this obviously seems suboptimal. However, what if the patient is newly diagnosed? What if they're treatment naive? What if they haven't had adequate molecular profiling and haven't been exposed to targeted therapies and immunotherapies? So this also can dramatically change the clinical picture. And finally, with age, more and more, age is just a number. And we've all had young 50-year-old patients with crippling medical complications and comorbidities. And this is technically much worse and higher risk than a 75-year-old patient that plays golf every day. So age is typically trumped, in my mind, by the patient's KPS and their medical comorbidities. In referencing the morbidity and mortality of brain metastasis surgery, it's a major consideration that we have to consider the cost of surgery in this patient population. For all of the reasons I've listed here, brain mets are generally a higher risk perioperative for medical complications compared to primary brain tumors, and they actually also carry a higher perioperative mortality. We also must consider that surgery will and can delay the initiation of systemic treatment, and that even a small postoperative complication like a wound infection can delay therapy for several weeks. Finding lesions that are in eloquent cortex, such as the motor area, are some of our toughest decisions because sometimes surgery can require a prolonged functional recovery, and a suboptimal outcome or a neurological complication can drop the KPS. And this functional decline can ruin the patient's candidacy for aggressive therapy. It can hurt their candidacy for clinical trial enrollment, which can both be detrimental to their outcomes, so also has to be very carefully considered. In terms of specific outcomes for brain metastasis patient, this is our recent analysis of national data, which included over 3,000 patients, and they reported overall that nationally in the US, there was a 30-day mortality of 4% for patients that have getting surgery for metastatic disease. We have an unplanned readmission rate of approximately 12%, and the most common reason for readmission of these patients is actually a thromboembolic event. And reoperation recurred in approximately 5% of patients, and the most common cause of reoperation was actually a postoperative hematoma. So moving from single brain metastasis, let's talk about multiple brain metastasis, which is a challenging patient population. Approximately 30 to 50% of patients with multiple brain metastasis present with multiple brain metastasis, and the desire for surgical consideration is increasing, especially in patients with larger lesions and that are symptomatic. And this desire is increasing for multiple reasons, but mainly because there's a desire for local control and to reduce intracranial tumor burden to avoid upfront whole brain radiation therapy. Unlike single brain metastasis, where there's a lot of data, there's actually no class 1 data to guide our surgical decision-making on multiple brain metastasis. However, there are several retrospective studies that have attempted to define the benefit of surgery in this difficult patient population. For example, in this paper listed here from Vandella et al., actually from the late 90s, it was a retrospective review that analyzed the outcome in 56 patients with multiple brain metastasis having surgery. Patients were divided into 2 major groups. Group A had resection of 1 to 2 lesions, but had unresected residual lesions left behind after their operation, while Group B had all of their lesions resected. And they compared the outcome between these 2 groups and a matched group of patients with a single resected lesion. And so the authors of this study reported their major finding was that patients who had all of their lesions resected had the same survival as patients who had a single lesion resected. In other words, no matter how many lesions the patient started out with, if all of their tumor burden was removed, their prognosis was in fact the same. And this was a very powerful finding at the time and has since been duplicated in modern studies. For example, this paper over here to the right, this 2018 study of 32 surgical patients with multiple METs showed similar results. And this paper actually also reported the significant neurologic improvement of patients with multiple brain metastases. So the functional benefit of surgery for patients with multiple brain metastasis was examined further in this recent paper from 2020. And this paper was from 2 institutions, and they did an analysis of 750 patients. And this paper actually was a rare paper that included patients with a large number of metastatic lesions, actually 1 to 34, with 25% having 2 to 3 mets and 14% having over 4 metastatic lesions. The major finding of this paper is that patients, even if they had multiple brain metastasis, had a significantly improved KPS after they had the resection. Also, a notable amount of patients, almost 60%, were able to have an improvement in their RPA classification from a class 3, which is the lowest class, to a class 1 or 2. And most importantly, improvement after surgery, this improvement of functional status facilitated the initiation of systemic treatment and ultimately prolonged survival. So in summary, the role of surgery in the management of multiple brain metastasis is still being defined. And currently, I think there's good data to support that removing multiple metastasis in a single sitting is safe. And then if they can all be removed, the prognosis is improved. However, I list here a couple of action items. There are still areas that probably could use further investigation. As I mentioned before, most of the studies that are published right now focus on patients with a limited amount of brain mets, like 1, 2, 3, 4 brain mets, similar to this patient here that I'm showing a picture of. So this patient with 2 lesions that are 3 centimeters, the benefit of surgical resection is very clear. But if you have the same patient and you added 5 subcentimeter lesions or 6 more lesions, when you start adding lesions, and it becomes less clear the impact of volumetric cytoreduction. So we need better data on this to define which patients benefit maximally from additional resection. Also, the impact on surgery in reducing the steroid dependence is not well defined, and this is especially important these days in the era of immunotherapy. And lastly, most published literature include multiple cancer types in their evaluation of multiple brain metastasis, but I think we probably need to get more sophisticated than this in the era of immunotherapy and targeted therapy, and dedicated pathology-specific data would be advantageous. And finally, all the data that we have is retrospective right now. It'd be very hard to do a randomized study on this issue, but a prospective study would help us better define our algorithm in how to treat patients with multiple brain metastasis. Okay, so moving on from multiple brain metastasis, I want to talk to you a little about the role of surgery in patients with this difficult issue of recurrent METs, failed SRS, or radiation necrosis. And radiation necrosis, as you know, is a radiation-induced inflammation which can cause disruption of the blood-brain barrier, significant cerebral edema, and subsequent neurological symptoms. And these symptoms can be very, very severe. And radiation necrosis is known risk of stereotactic radiosurgery. So these are all growing issues as patients with advanced disease live longer and longer with their metastatic disease. And specifically with radiation necrosis, there are two major contributing factors. One, we simply SRS more lesions. That's the long and the short of it. As whole brain radiation therapy has fallen out of fashion because of the cognitive side effects that have been well described in the literature. For example, this paper from our institution by Chang et al., for example. As whole brain radiation therapy has fallen further and further out of fashion, more and more studies have arisen supporting the use of upfront SRS for the treatment of more and more lesions. And for every lesion that you treat, there's a theoretical risk that that lesion can get radiation necrosis. So more lesions, more SRS, and then the problem multiplies. Secondly, a major factor is immunotherapy. And even though in the literature this topic is mixed because of the difficulty in studying this patient population, there's a growing body of evidence that supports the notion that immunotherapy may contribute to the development of radiation necrosis in patients treated with SRS. For example, this recent JAMA paper on the right here, published in 2018, looked at 480 patients treated with SRS and reported symptomatic radiation necrosis occurred in a higher proportion of immunotherapy patients than those not receiving immunotherapy. And so like SRS, we also love immunotherapy. It has really improved patient survival. Nivolumab alone currently is approved for over 10 types of malignancies. So the use of immunotherapy and SRS is just probably going to go up with time, making these issues even more pressing. So radiation necrosis leads to some unique challenges, which I've kind of outlined here. First, it can be difficult to distinguish from true tumor progression. Even with the help of advanced brain tumor imaging, it's very difficult to distinguish these radiographically or clinically. Because of the disproportionate amount of cerebral edema caused by radiation necrosis, sometimes the symptoms from radiation necrosis can be worse than the original tumor that you were treating. Third, the mainstay initial treatment of radiation necrosis is steroids to try and calm down the cerebral edema caused by this intense inflammatory reaction. And one of the big clinical dilemmas is the hope that the progressive enhancement and edema will subside with progressive steroid tapers and not require further intervention. However, as we know, radiation necrosis can be progressive, it can be irreversible, and it's almost impossible to know which patients are going to fly by steroid taper and which are going to require more aggressive intervention. For example, the patient in the middle there that I'm showing you with those 3 scans, the middle case is a small lesion that received SRS, had some mild increase in enhancement that later resolved after a short steroid taper. The bottom patient is another one, a small lesion treated with SRS, and unlike the case above, the radiation necrosis just didn't resolve. He was plagued with refractory radiation necrosis, he had seizures, he had weakness, and ultimately required an operation. And the difference in why one happens to one patient and the other is not very clear. And also the chronic use of steroids can have potential medical side effects and consequences that we need to be aware of. And then from a surgical perspective, when you're going to intervene in these patients, you have to do a careful calculation of the surgical risk for a lesion that's not actually cancer, which is very important when you're dealing with lesions in the eloquent cortex. So here I just put in here a few examples to illustrate the heterogeneous presentation of this patient group. So on the left is a patient that had surgery for metastatic esophageal cancer, came with leg weakness, had a gross total resection followed by SRS and adjuvant SRS to the cavity, and presented a year later with crippling weakness in a wheelchair, and advanced brain tumor imaging indicated that he had a lesion that was mixed treatment effect and actual tumor progression. On the right is a totally different patient. It's a 61-year-old lady with metastatic melanoma treated with SRS to a small right frontal lesion, as you can see there, with a small amount of edema. Approximately a year later, she came in with some increased enhancement, some headaches, increased edema. She was able to be temporized with steroids. And then 3 months later, this small lesion came in with terrible edema. She had crippling headaches and ultimately required an intervention. So what kind of interventions do we have, and what are the salvage treatment options for patients with this difficult problem? So first, we have open surgery, which has been proven to be very effective and reasonable option to address lesions following failed SRS. Here are some of the strongest data I have presented here from the literature. The largest study is on the left that had 58 patients who required resection for brain metastasis following SRS. And they reported a median survival of 7.5 months and a surgical morbidity of only 6%, which is not that bad. 6% is pretty akin to treatment of naive lesions. Additionally, they reported that a major predictor of post-op survival was actually the interval between the original SRS and the resection. That if the interval between the SRS and the resection was less than 3 months, this was associated with significantly worse survival. And notably in this study, no patient had a resection within 3 months of their SRS lived more than 1 year. So this I think is an important factor in deciding who to do an operation on in the setting of recurrent brain metastasis. In this more recent study, 2020 study on the right here, they actually looked at 48 patients undergoing salvage surgery. This paper actually reported an even higher median survival of 20 months after salvage surgery and a pretty good local control rate of 76% at 1 year. Further, this patient was very important because it highlighted the palliative benefit of salvage surgery, with 75% of patients having improved neurological symptoms following their resection of this recurrent lesion. So in addition to surgery, there's an alternative surgical option for recurrent mets and radiation necrosis, and this is interstitial laser ablation, also called LIT. So LIT is a minimally invasive procedure that consists of a laser probe inserted under stereotactic guidance into the tissue of interest in order to destroy it. So when the laser is entered and hits the lesion, the tumor interacts by absorbing the laser photon, and this is translated into a thermal energy. And this thermal energy is generated inside the lesion and causes internal tumor necrosis. To the right over here is actually a published algorithm from some of our faculty at MD Anderson who are very experienced in LIT in decision-making and deciding which patients should have LIT and what should be the timing and decision-making of which patients should have LIT versus surgical resection. Overall, the ideal lesion to be treated with a LIT is a well-circumscribed lesion. Ideally, it'd be a small lesion, no bigger than 3 to 3.5 centimeters, or less would be even more ideal. So larger lesions can be treated. It's just that they'd have to have multiple probes and it's more complicated. So typically, smaller lesions are favored. The main advantages of LIT compared to open resection is the ability to treat lesions that are surgically less accessible or maybe more difficult because they're in less accessible locations like the thalamus or the caudate. Also, LIT has a smaller incision, has shorter healing time, shorter hospital stay, and potentially can get patients quicker to their back to the initiation of their systemic therapy. So these are several advantages of reason to consider LIT over open surgical resection. So we talk a lot about what predicts a good surgery. So I thought it'd be helpful to discuss what predicts a good LIT. And so this paper actually is also out of our shop. It's a 2020 study where some of my colleagues evaluated the predictive factors associated with local recurrence after a laser ablation. The study included 61 patients, treating a total of 82 lesions, and the recurrence, 46 of them were treated for recurrence, 3 for radiation occurrence, and 5 were actually newly diagnosed lesions. In their multivariate analysis, they identified 2 major predictors of local recurrence after LIT. First is that patients that had true tumor recurrence were more likely to recur faster than patients that were being treated for radiation necrosis. And secondly, they reported that incompletely ablated lesions had a shorter time to local recurrence than patients that had a complete ablation. Note that the complication of LIT in this paper was 26%, which is a little higher than for open surgical resection. But I caution with the caveat that these patients that are selected for LIT are usually a higher risk population because of they're not as medically fit for a big operation, they have thrombocytopenia, or they have difficult to assess intracranial lesions. So in summary, I hope that I've been able to cover many of the aspects that are important to us and in terms of decision-making and surgery. So we all agree that brain metastases are an impactful cause of advanced cancer. And as a team, along with surgery, radiation oncology, medical oncology, our management has evolved to focus on reduction of local recurrence, prevention of neurological death, and maintenance of cognitive function and quality of life. The role of surgery is well established, especially for single brain metastasis. Resection in the setting of multiple brain metastasis is advantageous for select populations, but more detailed prospective studies, I think, would be required to better define the population that will benefit most from cytoreduction. And then recurrent brain metastasis and radiation necrosis are going to be growing problems that we're going to be working through for a while because of the increased use of immunotherapy and stereotactic radiosurgery. And salvage surgery and LIT offer an opportunity to palliate neurological symptoms and obtain local control. So I just want to say thank you. I always am nervous about making these thank you slides that I'll forget somebody, but I just want to thank everybody who has contributed to building the brain metastasis program at MD Anderson.